Hello everyone, and thank you for participating in this webinar. Before we begin proper, here are some general instructions. We have muted all your microphones, so if you have any questions or feedback to give, please use the question and answer panel that you see in front of you. Now, this live webinar will be recorded. So once again, a warm welcome to everyone. My name is Cheng Lee, and I will be the chair for today's webinar entitled Diabetes Remission, Update on Evidence, Guidelines, and Recommendations for Research and Practice. Today's webinar is brought to you by the Center for Transformative Nutrition and Health, or otherwise known as the Ctnh at the International Medical University in Malaysia. Now, one of the objectives of Ctnh is to solve diet and lifestyle-related diseases for the nation. And today, the focus will be on type 2 diabetes. Many of you are already familiar with the fact that Malaysia has the highest rate of diabetes in the Western Pacific region, and that this prevalence is on an increase. We also know that the longer a person lives with diabetes, the higher their incidences of complications and the poorer their quality of life. Now, the cost of diabetes, if we look at it in monetary terms, it is estimated to be about $600 million per year. In lifespan terms, the global burden of disease data showed that type 2 diabetes, when compared to other conditions, is actually a determinant of premature death. So as healthcare professionals, it is high time we change the way we think about how we manage diabetes. It is not enough to just control diabetes. We need to conquer this urgent condition. Now, evidence shows us that diabetes remission is possible. Type 2 diabetes is no longer a diagnosis that our patients just helplessly accept. So here with me today, we have a lineup of 4 distinguished speakers who will show us how we can conquer diabetes. And this webinar will close with a panel discussion involving all speakers. I would now like to introduce the first speaker, Professor Anthony Leeds. Now, Professor Anthony Leeds is a visiting honorary adjunct professor at the School of Health Sciences, International Medical University, Kuala Lumpur, Malaysia. His current research interests concern the use of low energy and very low energy diets for weight management in clinical practice. Prof Leeds works with colleagues at the Parker Institute, Frederiksberg Hospital in Copenhagen, where he is an honorary senior research fellow. He also holds honorary appointments at the Universities of Copenhagen, Denmark, and Glasgow, Scotland. He was senior lecturer at King's College London until the year 2007, medical director of the Cambridge Weight Plan until 2019, and is now chairman of TDMR Europe, the European industry group that works to optimize legislation and educate people about obesity, its comorbidities, and the role of diet in management. Prof Leeds, the stage is yours.
Well, thank you very much indeed for giving me this opportunity to speak. And what I want to do this afternoon is to consider some of the issues relating to diabetes and the importance of weight loss, but also just to remind everybody that amount of weight loss that we're going to talk about can also be beneficial in other comorbidities. And many of the patients we see will, of course, have more than one comorbidity, and most of our older people with diabetes are likely to have other conditions. My disclosures have already been given. I chair the European Industry Group. And what I'm going to do is to discuss why more weight loss is more effective than rather less weight loss, look at some recent guidelines, and then look at some of the evidence for why greater weight loss may be beneficial. The set of guidelines I'm going to look at are some that are now 8 years old. In fact, the American Association of Clinical Endocrinologists produced a very extensive review of the evidence and published it in July 2016. And the interesting thing about this, and I've extracted here the key figures from their extensive tables based on their, I think it was 400 pages of evidence that was discussed. It's very interesting that the amounts of weight loss suggested for individuals with body mass index over 25 who need to lose weight is that 5 to 10%, or indeed in some cases 15% of weight loss is the amount that is actually required in order to get a clinically meaningful amount of effect and benefit. And you'll see here figures for 10% for metabolic syndrome, 10% for prediabetes, and 5 to 15% for type 2 diabetes. We also have to remember, of course, that when we're considering weight loss, there are a number of methods. Bariatric surgery is an established, effective method which has an effect on risk of development of diabetes, on the metabolic control in diabetes, on cardiac risk factors, and also risk of death. Conventional diets, which result in very much lesser amounts of weight loss, can have small effects. They certainly are very beneficial as far as diabetes control is concerned, but the effects are relatively small, and the lipid effects are probably much more determined by the nature and quality of diet rather than weight loss. Recently, of course, there's been particular interest in the use of total diet replacement. And since most of us will be referring to this morning, I thought it important to begin by describing exactly what it is. It's a formula diet formulated to provide all the micronutrient requirements on a daily basis, all vitamins and minerals, adequate amounts of protein and essential fat, but of course a restricted energy amount. This means that for a low energy diet of around 800 calories, this would provide around about 80 grams of carbohydrate, about 40% of energy, and 80 grams of protein. It is possible to use these as a very low energy diet that's under 800 calories. So it might, for example, be 600 calories per day. But the critical thing is that this results in a larger energy deficit between that which is provided in the diet and the daily requirement, whether it's VLCD, VLED, or a low energy diet. This results in greater weight losses. In many of the clinical trials published recently, this has given an average weight loss in women of around about 1.3 kilograms per week and 1.5 kilograms, and even more sometimes in men. Interestingly, this type of diet seems to result in high compliance. In a large trial that I'll refer to in a moment on prediabetes, 91% of individuals were actually able to follow the diet for 8 weeks. So I'm going to begin with diabetes prevention, and the key thing that everybody accepts now is that weight loss is the critical variable in primary prevention of diabetes. And of course, the US Diabetes Prevention Program showed that for every kilogram of weight loss, there was very roughly a 16% reduction of risk at 3 years. That gives us a very clear clue that it is important to achieve a good weight loss and to maintain a good weight loss throughout. Evidence, of course, going on way beyond 3 years and 5 years now. There was a recent study funded by research funds from the European Union, which looked at prediabetes in 8 countries, 6 across Europe and also in Australia and New Zealand. A very large number of individuals were screened. 2,224 people began the program, and the program consisted of an initial weight loss with a total diet replacement for 8 weeks, so 800 calories, formula diet, no conventional food for 8 weeks, and then reintroduction of conventional foods and management of diet by different types of diet, either low glycemic index, higher protein, or higher glycemic index, lower protein, and 2 different exercise levels. As I said earlier, 91% completed the diet successfully with an average weight loss across all groups of 10.7 kilograms by 8 weeks, which is consistent with most other published trials. Slightly greater weight losses for men of around 11.3 kilograms. For women, it was about 10.2 kilograms. And 2/3 of them were not pre-diabetic by WHO criteria at the end of the 8-week period. They then moved on to the 3 years of weight maintenance. Now, one of the key things in this was that the frequency of interaction with the healthcare professional managing the individuals was extended as time went on, so that towards the end of the program of 2 to 3 years, they were only seen every 6 months. And I think that in retrospect, there was an error there in that they should have been seen much more frequently. And this did result in rather a disappointing completion rate of about 50% of participants. 962 completed it. But interestingly, of those for whom there is data at 3 years, only 6.4% developed diabetes, which is much less than occurred in the Finnish and US diabetes prevention programs, in which at 3 years the weight loss was around 3 to 4 kilograms, whereas it was around about 6 kilograms in this particular trial. What this suggests is that it may be very important to start a diabetes prevention program with a really effective weight loss, perhaps using total diet replacement, and then obviously have an adequate maintenance program to follow it. Now, Michael Lean in a moment will talk more extensively about the diabetes remission trial, but it's important that I mention it. It's a trial that was undertaken in the United Kingdom, in Scotland, in practices around Glasgow, and in Northern England, in practices around Newcastle. It was a cluster randomized trial based in primary care, comparing usual care with an 810 calorie total diet replacement, followed by a very well managed and extensive weight maintenance program managed by healthcare professionals using the Counterweight Plus dietitian-led program. Patients were BMI over 27 and participants were followed up to 5 years. We now have the results at 2 years and we're eagerly awaiting the 5-year results. Michael will comment on those in a moment, but I've just picked out one figure. Reason for doing so is it shows the clear relationship between the amount of weight loss at 12 months and the proportion in remission, and you see the stepwise, in effect, dose response to lower amounts of remission at less than 5 kilograms weight loss maintained at 12 months, whereas over 15 kilograms maintenance, it's 86%. And the key message from that is if you pool the values for all those who maintain more than 10 kilograms weight loss at 1 year, is that remission occurs in 2 out of 3 individuals at that level. Now, Roy Taylor, working in Newcastle, undertook a study on a subset in which he scanned the livers and pancreas of these individuals. He also divided the participants into what were defined as responders, those who had gone into remission, and non-responders, those who had not. Those who were responders lost slightly more weight and regained less. Those who were non-responders lost less, you see 13 compared to 16 kilograms, and regained more, suggesting that to some extent those who were more effective in achieving weight loss initially and maintaining it were the ones who achieved the remission. Also interesting to note that in fact remission was more likely in those who'd had their diabetes for a shorter duration, 2.7 versus 3.8 years. And also his scans, and I've picked out one of his MRI scans showing the liver fat content. Top left there, you see the liver fat at 30.4% at the beginning of the period and 1.3% at the end of the weight loss period. So what we can say is that responders lost more weight and regained less, perhaps reflecting tighter energy intake control. Next, I want to turn quickly to studies done in Copenhagen on older people with obesity and also knee osteoarthritis. This is a group in practice which is very difficult to manage. If they present with diabetes, it's difficult to encourage them to lose weight because they're in pain and sleeping badly. This study shows that formula diet programs, either a very low calorie diet or a low calorie diet, can achieve a good 12-13% weight loss initially over an 8-week period. And we also showed subsequently that we were able to control this weight by fairly intensive management by dietitians. Important to note that there was a good symptom response. And of course, it is pain that is the most troubling symptom that these people suffer from. What we can say, to summarize a number of publications, is that weight loss of 10% in elderly people is possible. Pain reduction is sustained if you maintain the weight loss. Inflammatory markers are reduced, and MRI scans show that what is actually happening is that there is reduced inflammation in the fat pad around the knee, and also synovial membrane inflammation is reduced. We also know that total diet replacement does have an influence on nutritional status. In this study, we measured vitamin D status, bone mineral loss, and so on. And the vitamin D results show very clearly that the proportion who were deficient at the beginning were reduced by 16 weeks, and by 68 weeks, 1 year into the maintenance diet, there were even fewer of them who showed evidence of vitamin D deficiency. So it's important to bear in mind that total diet replacement doesn't just achieve weight reduction, but can also influence some aspects of nutritional status. There was also a blood pressure reduction with the weight loss, and where the weight loss was maintained, then the blood pressure reduction was also maintained, and that had an effect on cardiac risk. The actual blood pressure values for that particular study are shown here, and you'll see that by the end of 16 weeks, the point at which the weight loss was greatest, showed the greatest blood pressure reduction, but this was maintained eventually in a total of 4 years, quite effectively, at 10 millimeters of mercury of systolic pressure on average and 6 for diabetes, for diastolic blood pressure. In direct, which Mike will talk about a little bit more, there was also an effect on blood pressure, as might have been expected. This is a figure showing the subdivision into the different groups according to how many antihypertensive agents they were on initially, but you'll see in all cases there's a reduction over the initial weight loss period with the total diet replacement of 7 to 10 millimeters of mercury. And for those who had no treatment and had no hypertension, there was a 14 millimeters of mercury reduction of blood pressure. And if you look at other trials with this type of intervention, you'll see similar results. In the direct trial, this resulted in a reduction of use of medications for high blood pressure in 68% of individuals compared to 39% in those who were in the control group in the best practice group. And as you'd expect, the numbers of individuals using anti-diabetes medications was also reduced. Note also the evidence for the improvement in quality of life in the active intervention group. I want to now turn on to obstructive sleep apnea, which is important in the context of diabetes because a good proportion of individuals with diabetes are affected by obstructive sleep apnea. And most clinical guidelines include weight reduction as a core feature of management, and yet in actual fact, in practice, except perhaps in Finland and Sweden, a big weight loss with a total diet replacement is not usually part of management. These are the results of a trial undertaken in Sweden, using initially a very low energy diet of 600 calories in obese men with severe and moderate sleep apnea. As you can see in the chart there, if you look at the blue line, a big reduction initially by 9 weeks. And then there was fairly intensive management within the obesity unit right the way through for 1 year, and the weight reduction was maintained. The initial improvement in sleep apnea was maintained throughout the year, and about 10% of them had a total remission of their obstructive sleep apnea. I've chosen to show you that particular paper because there's also a figure in it which illustrates the relationship between the amount of weight loss and the amount of change in the apnea-hypopnea index. And you'll see that it sort of suggests perhaps that a 15 kilogram weight loss would be a good target to have for these individuals, although it would have to be varied according to the severity of the disease in that individual. So this does tend to suggest, as do other papers, particularly from Finland and other papers from Sweden, suggest that we ought to be more aggressive about weight management in people with obstructive sleep apnea. To a presentation that was made again by some colleagues from Copenhagen at the obesity meeting in Maastricht in May of 2022, when they studied people with obesity but no other comorbidities, and with no comorbidities of obesity. Sleep was significantly improved by an 8-week total diet replacement. So these people achieved 12 to 15 kilograms weight loss, but also a very interesting observation that they made, which was that the sleep duration prior to the weight loss program determined their ability to maintain weight at 1 year after the initial weight loss. And for those who slept less than 6 hours initially, there was much more weight regain. Now, the full paper is not yet published. Obviously, it will need to be followed, but I have long thought from my observations made on patients in the clinic that even in the absence of obstructive sleep apnea, a very large weight loss of 10 kilograms or even 15 kilograms seems to actually improve sleep quality, which in turn, of course, can be very beneficial with respect to all sorts of other aspects of the patient's perception and also to quality of life. So I'm suggesting here something which will need some further investigation and support, that in addition to talking to our patients about weight management, we probably do need to start to talk to them about their sleep and give them guidance. And I know from discussion with colleagues, including Louise, we had a discussion yesterday about individuals who had very bad management of their sleep and for whom correction of that was very beneficial in helping them to maintain their body weight. So I'm going to summarize then by pointing out that most targets are somewhere between 5% and 15%, which of course assumes that we're dealing with the majority of individuals that we see in Europe who might have weights up to say 130 kilograms. We're not really talking about the increasing proportion of people who we see with super obesity now in the United Kingdom and in some other countries of individuals with weights up to 200 kilograms. Those are a different target group. Bariatric surgery has a place, GLP-1 agonists have a place. Following discussions with colleagues, I think it's highly likely that in the end we'll be using GLP-1 agonists for a specifically targeted group, those who have perhaps low baseline GLP-1 levels and those who have demonstrated that they have difficulty maintaining weight, rather than everybody. Formula diets can deliver the weight losses that we need. Conventional diets can do so occasionally. All of us in practice have seen the individual who had scope for change and who made big changes. However, we always have to bear in mind the cost, safety, and feasibility of all these different interventions. Clearly, we cannot deliver bariatric surgery for all patients. Clearly, conventional diets are very difficult for people to achieve weight loss, and then actually weight maintenance after conventional diets is jolly difficult, although we're learning more and more about weight maintenance as each year goes by. For diabetes prevention, we've known for a long time that weight loss is key, and there may well be merit in trying to achieve a greater initial weight loss prior to putting people on their long-term weight maintenance program. Diabetes remission, Mike will talk more about it in a moment, but it looks as though we should aim to get 10 to 15% weight loss in those who are able to do so, and then maintain it if possible, to maintain the remission for as long as possible, but recognizing that inevitably with aging and with the lapse of time, that people will tend to drift back towards a diabetic state. In obstructive sleep apnea and also in knee osteoarthritis, greater weight losses do give greater benefit. I haven't shown you slides of the dose response effect in knee arthritis, but it's obvious and it's mechanically true that the more weight loss that is lost, then the forces that apply to the joints are reduced. And so to summarize now with regard to total diet replacement, there can be fast weight loss, which is motivating for the individual. After just 1 or 2 weeks, they do appreciate the changes that they feel, and that can be highly motivating. Compliance can be high, isn't necessarily so. It does require that the program is delivered in an appropriate way. Safety profiles are published and are very good. It's also cost effective. There are cost effective analyses undertaken by the Glasgow group and by other groups, and there is also reduction of medication costs. So at that point, I will stop. Thank you very much indeed.
Thank you very much, Prof. Tony. That was really good message to start off the webinar. Weight loss seems to drive a lot of things, remission, prevention, helps to address knee osteoarthritis, obstructive sleep apnea, and now we're talking about sleep hygiene. Really important message there. Thank you very much. Well, we're moving along. It's my pleasure now to introduce the second speaker for this webinar, Professor Michael Lean. A little bit about Professor Michael Lean. He is a professor of human nutrition at the University of Glasgow and consultant physician at the Glasgow Royal Infirmary. He is also a visiting professor at the Universities of Otago and Sydney. Now, Prof. Lean has a very extensive research and teaching portfolio, but most recently, he is the principal investigator of several research projects, including the much acclaimed Diabetes Remission clinical trial that we know as DIRECT, and NIHR-funded weight loss for long COVID, known as the REDIRECT, collaborative dietary diabetes remission projects in Nepal and Australia, and pharmaceutical trials. Over the years, he has published over 650 scientific articles and books, and his H-index is 117. His awards include the Diabetes UK Rank Prize Lecturer 2014, Memorial Lecturer 2020-21, the Tenovus Medal for Research 2017, elected Fellow of the Royal Society of Edinburgh, Scotland's National Academy 2018. Now, I don't know where he finds the time to do this, but outside of research, he makes and plays fiddles and has the occasional escape to climb mountains. Ladies and gentlemen, Professor Lean.
Thank you very much indeed for that very generous introduction, which went on for a long time. I am going to move smartly, if I can, onto my presentation. Thank you. So what I'm going to do is to go through fairly briskly the DIRECT trial, which Tony Leeds has already introduced for you, and to try to explain where this fits into management and indeed how it's being viewed across the globe. So my disclosures are shown here, and I'll just mention right at the bottom there that I try to put up the slides and certainly all the publications from DIRECT, the Diabetes Remission clinical trial, on this website directclinicaltrial.org.uk. And the .org.uk means that it's a charity, not a commercial program. So just to fill in, since you asked me to speak about guidelines, I have been involved over the last 4 years in designing new nutritional guidelines for the European Association for the Study of Diabetes. Having previously done this first in 1988, which seems a very long time ago now. I wasn't actually doing that one, but I picked up the bits in 2004, and we've had guidelines which have emanated from those European guidelines in the UK from the British Diabetic Association as well. So writing guidelines is something we've been doing for many years, and we're getting sort of better at it. And what's also good is that people are beginning to read guidelines, understand better how to put them into practice. And at the very beginning, I would say that guidelines are not written as a sort of a blueprint for telling people how to manage their patients, but they're setting standards which can be interpreted or should be interpreted for each individual patient. At any rate, in 2018, the EASD commissioned a new set of guidelines because things have moved on, and this is what we've been doing. Importantly, they now require the use of GRADE, which is the grading of recommendations, assessment, development, evaluation, and defining the inclusion criteria for evidence which is cited. And we also now rely heavily on meta-analyses, and we've carried out really quite a large number of meta-analyses, and we've used the AMSTAR system for quality assessment there. So writing guidelines has become much more technical. I'm glad to say we've now finished that work. It was presented in Athens at the Diabetes Nutrition Study Group of the EASD, and then just last week in Stockholm at the annual EASD meeting. And what we're now doing is simply refining, possibly refining the wording, the text throughout all the membership to make sure we have a pretty strong consensus. And each guideline is a short statement followed by a commentary to explain why it's considered to be important and why we didn't say something different. And then it will go to the ASD Council and finally to be published in Diabetologia. The topics I've just listed at the bottom here are things that the guidelines are now addressing, all in the context of diabetes, but principally mainly type 2 diabetes, although some of them do apply to any people with diabetes. And it starts off with a section on prevention, because we now have really quite a lot of evidence on prevention of diabetes, including nutritional efforts. The energy balance and weight management, which I led, and then separate sections for the macronutrients, carbohydrate, fat, protein. Moving on to food-based approaches, and an interesting new development, which is to tackle therapeutic diets and traditional diets, which are really very different, and we can discuss that later. And then finally, there's a discussion section on the impacts of environmental sustainability, which has a bearing on how the recommendations might be interpreted by individuals or by different countries on food processing and on the need for individual patient support. At the back of this, I can return to another guideline, which was the Scottish Intercollegiate Guideline Network Guideline on Obesity. The first was in 1996, and that was actually the very first clinical guideline that was ever written for obesity. It came from Scotland. It was picked up very quickly in the United States, and they more or less copied it from the Institute of Medicine there, and subsequently by NICE in England and a number of other countries. The Scottish guideline was revised in 2010 and informed quite strongly the World Obesity Forum and WHO recommendations. So one of the important statements here is that obesity, which is the underpinning problem behind type 2 diabetes, is not a BMI. It's not a BMI of 30 or 28 or 25. It's a disease process which starts in young people, and it's a disease process of fat accumulation, which has many clinical adverse effects at different levels of BMI. So you can't determine for any individual exactly when they're going to get diabetes, if they're going to get it. If they have the genetic predisposition, they will probably get it when they have gained a certain amount of weight, but that could be relatively little and it could be a great deal. That's important. One of the questions we've had already on the chat line here was what about the people with a BMI of 23 who have type 2 diabetes? And that is, I'll come back to towards the end of the talk. It's an important issue. And so the guidelines are evidence-based, and they deal with obesity, but also with the diseases mediated by obesity. And now moving to the European Association guidelines, the list is here. It's specifically for obesity and weight management. And I'm not going to read these in any detail, but there are 6 linked recommendations, which are supported by a grade, which I put in yellow here, to show you how strong the evidence is. And really, just looking down those grade listings, you can see that the evidence is really very strong for weight management in type 2 diabetes. And firstly, it's probably almost self-evident now that overweight people with diabetes should be supported with evidence-based treatments, not just general advice, but an evidence-based program is what is needed, because this is a very serious disease, as many Leeds has pointed out, and there are many other factors lying behind that. We've recommended that there's a range of diet types and macronutrient compositions for weight management, which are all supported by evidence, and there's really nothing to choose between them. There are huge numbers of studies which have compared high carbohydrate, low carbohydrate, high fat, low fat, etc. There is no difference between them. When you do randomized controlled trials, there is no difference. So there's no special magic in low carb diets, which unfortunately has caused a lot of confusion in the lay literature and confused quite a lot of doctors and dietitians as well. We've recommended that nutritionally complete formula diets can be used safely, and that's important. There's some ancient misconceptions, either as total diet replacement or as a partial diet, as a meal replacement program, particularly for long-term maintenance. Recommended again that the extreme diets, high carbohydrate or low carbohydrate, are not advisable because of safety issues, which are implied for diabetes, although the evidence comes from general observations. We've now recommended for the first time that remission is a target for type 2 diabetes, and that means a hemoglobin A1C less than 48 millimoles per mole, without the use of glucose-lowering medication for 3 months, as defined now internationally. And that should be achieved through sustained weight loss. That is the only evidence-based approach which can be recommended. And we've gone on to recommend the approach really quite strongly, which has now been supported not only by DIRECT, but by the DIADEM-1 trial based in Qatar, which produced very similar results. So that's where recommendations are lying now. The background to DIRECT, and Tony Leeds has given me quite a lot of detail, so I won't repeat all of that. The background to DIRECT was firstly, the very obvious observation, and this is from the Nurses' Health study, that type 2 diabetes is driven very, very strongly by gaining weight, and you could put waist circumference there instead. If you remain at a BMI of 21 or 22, it is very unlikely that you'll get type 2 diabetes. If you do, I'll come back to that, it almost certainly means you are very sensitive to gaining body fat, and it will probably be reversible by quite small amounts of weight loss. However, the principle here is that this relationship with massive relative risks of diabetes, running up into tens and even hundreds, is an indication that this is a causal relationship. So weight gain causes type 2 diabetes, and that's important because it means it is potentially reversible. We then look at the metabolic factors which drive type 2 diabetes from pre-diabetes in younger people. And all these elements, including insulin resistance, the increased lipolysis in visceral fat, then ultimately beta cell decompensation, all of these things we know from other research are aggravated by weight gain. So again, it suggests that by removing the weight gain, we might be able to at least delay or slow down, perhaps reverse that process into developing diabetes at a cellular level. Even stronger evidence comes from these studies which have shown prevention of type 2 diabetes in people who have prediabetes. So these are the people on the slippery slope towards diabetes. We can identify them with hemoglobin A1C now between 42 and 48 millimoles per mole. These people, given quite modest weight loss, and this is a weight loss on the left panel here, it's a very sensitive slide, weight loss of only about 7 kilograms in the first instance and not entirely maintained for 4 years. That is enough to eliminate the incidence of over half new diabetes. And there's a legacy effect from the same trial. This is the diabetes prevention study in North America, and there are several trials internationally showing exactly the same thing. So we know that that process can be blocked and delayed for many years by quite modest weight loss. And perhaps we could reverse the entire disease by weight loss. And I then go back to a very old study from Aberdeen, from Scotland, which was published in 1990, which looked at the people who are overweight, BMI over 25, with type 2 diabetes at the first appearance at the diabetes clinic when they turned up there for advice. And they were all then advised strongly to lose weight. And this is the work of one of my bosses, my mentor, John Stowers, who believed strongly that weight loss was the answer. He had no evidence, but his own clinical observations. At any rate, all the patients saw the dietitians regularly for their first 12 months. And these are all people with type 2 diabetes. With no weight loss, their patients lost about 7 years of life. The average age of onset in those days was quite old. It was about 64. It's obviously come down a long way since, but 7 years of life were lost if they did not lose weight. If they lost weight over that first 12 months with the help of the dietitians, they lived longer. And if you draw the lines I've done there up at the top, at 14 kilograms, 15 kilograms, where our evidence ran out, not many people did that, but those who did lived as long as people who'd never had diabetes. So it looked as if the whole pathological process might be reversed by substantial weight loss. And that evidence stayed with me for very many years until we were able to design the direct clinical trial. We did that with the help of a little bit more evidence that came from Australia. This is John Dixon's study from Melbourne. And these are individual patients who received either a gastric band or continued the usual diet at the diabetes clinic. And at 2 years, the open symbols show that those ones who lost more than 10 kilograms or 15 kilograms, and there's so few patients here, we don't know if it's 10 or 15, nearly all of them, 83%, if they lost 15 kilograms or over 10 kilograms, they were in remission from their diabetes for 2 years. And that suggested, because we have now better methods for dietary weight loss, we might be able to do that in routine practice. Now, that was what drove us with a little bit more evidence from Roy Taylor, who carried out a very small pilot study showing that 15 kilograms did appear to normalize some aspects of type 2 diabetes. We put together this study, which was funded by Diabetes UK in Scotland, mostly the south of Scotland, as Tony Leeds pointed out, although some of them came from quite far north, and then from several places around the northeast of England. And this was a cluster randomized trial. So we went to GP practices, primary care practices, not to individual patients. And we asked the district nurse or the practice nurse, or if they had a dietitian who came to the clinic, to help the patients to lose weight. So this is a cluster randomized trial across the country, conducted entirely in primary care. So the patients didn't come into hospital, apart from a subset in Newcastle who had some metabolic investigation. And the design was very simple. All of the patients, control group and intervention, followed the best practice guidelines. That's the SIGN guidelines in Scotland, NICE in England. The intervention randomized practices received also the Counterweight Plus program, which Tony Leeds mentioned. We had a very high response rate. This is a very attractive study for patients. They didn't want to have to carry on taking tablets for diabetes if they could manage to get rid of the diabetes. They were very typical patients, and you'll see here that their average age was, in fact, 54. So that was, and they had had diabetes at that stage for about 3 years on average. So that is very close to the normal mean age of diagnosis, around about 51 now. It's come down because people are getting fatter. BMI 35, hemoglobin A1C 59 millimoles per mole. We've selected people who had not had diabetes for longer than 6 years, because longer duration makes it more difficult to reverse. And at that stage, our patients, none of them had insulin. And that would, on day one, we asked our patients to stop their glucose-lowering medications. And most of them were on metformin, some of them on 2 medications. We asked them to stop those drugs completely because we did not want them to have hypoglycemia when they went on to total diet replacement. And then we also asked them to stop their antihypertensive medications and diuretic drugs because there's a high risk of postural hypotension, falling, banging heads, when people go onto a firm diet. And as Tony mentioned, it was just over 800 calories a day, formula diet for 3 months, 12 weeks. We allowed our patients to have breaks, that's to increase the acceptability. If they had weddings or holidays, we gave them advice not to put on weight in that time, but they could then extend that 12 weeks or the 12 weeks of treatment over a longer period. Food introduction was done meal by meal with the help of our very skilled dietitians. And that was really the most tricky period for the patients themselves. They found it quite threatening to have to choose foods and not risk going going back to their old habits. And that went on to long-term weight loss maintenance. The detailed steps are shown here. The formula diet is very like any other formula diet. It's nutritionally complete, so it's entirely safe. The exact calorie content very, very slightly, but if you include some of the milk that was involved, 830 calories a day. The food introduction, that was the time when we asked our patients to try to increase physical activity, and we gave them step counters to try and do that. We did not ask them to increase physical activity whilst on total diet replacement. And that is because trying to ask them to do two things at the same time generally makes it more difficult to do one thing well. And we didn't want to corrupt their efforts to lose weight. So we asked them to increase physical activity. In the end, we found they just didn't. We measured it using accelerometers. They did not increase physical activity despite our efforts. So this was something they found very difficult. The weight loss maintenance program was food-based, using very typical foods found in Scotland or in England. We did not aim for any kind of unusual high carbohydrate or low carbohydrate diet. It was very typical, around 50% of calories from carbohydrate. But we did offer relapse management. If patients regain 2 kilograms, we recommend they get in touch, and we could put them back onto the formula diet for a period of 2 or 4 weeks to get them back on track. And they were seen, as I said, in primary care. The design was aimed to get a remission rate of 22%. That was pretty bold. It was because our public health doctor said if we could get more than 20% remissions, this trial would mean we would have to change our management of diabetes nationally. And that was what we set out to do at 1 year. That was the target for 1 year. We, in the event, and many people know this already, we exceeded that enormously by remissions of 46%. And that was with an average weight loss of 10 kilograms. So about half the patients were in remission with about 10 kilograms or greater than 10 kilograms weight loss. And a very few in remission in the control group. That caused a lot of excitement initially. At the second year, we still had a remission rate of 36%, which is well above the 1 year target, and the mean weight loss at that stage of 8 kilograms. And it's interesting now to reflect that the change there, the drop in remission rate between 1 year and 2 years, was entirely because of 15 individuals who regained weight to a point closer to their baseline than 10 kilograms. So it seemed as if they could stay 10 kilograms below baseline, they were very likely to remain in remission. And that was an important message. Tony showed a version of this slide, which basically shows how powerfully the weight loss produces remissions. At the right-hand side of this slide, you can see the weight losses with greater than 15 kilograms weight loss. And that's 86% at 1 year, 82% at 2 years, which is almost exactly the same as John Dixon's bariatric surgery result with greater than 15 kilograms weight loss. If you put together the 10 and 15, so people with over 10 kilograms weight loss, there was 70% had remissions which were sustained for 2 years. So losing 10 kilograms in European people, enough to get 70% into remission for at least 2 years. Again, Tony showed a version of this slide, which looked at their blood pressures, showing this remarkable fall, dramatic fall in the people who were not on medication for their blood pressure. Those people in the green and yellow were the people who stopped medication, either one or more than one medication for blood pressure. And that was how their blood pressures behaved. So they also fell over the period of total diet replacement. If we had left them on their medication, they might have seen much more dramatic falls, and some we know suffer postural hypertension. So this is a proof that weight loss is a very powerful treatment for hypertension. When we stopped their medication, we did not stop treatment. We replaced their drugs with a more powerful treatment, and that was weight loss. With the reduction in diabetes, with the reduction in blood pressure, lipids also improved substantially. All these pointed to evidence that we would predict patients would live longer, just as in that old Aberdeen study. We also had evidence for improved quality of life, substantially improved with major weight loss. So they lived longer, felt better. And because of all the reductions in medication, the fewer visits to hospital, the fewer admissions to hospital, the medical care costs were reduced in DIRECT. So this is a very good news study. Subsequently, and indeed in the last 2 years of DIRECT, we had to use a fully remote system for weight management. And these are some data from the same Counterweight Plus, which program, which are now being delivered entirely remotely. So the formula diets are sent to people's homes. They don't have to leave home to get it. They use Zoom and WhatsApp and emails and even the old telephone for dietitians to support the patients. And the weight losses we're seeing now in unselected patients, 15 kilograms weight loss at 12 weeks, 15.8 kilograms weight loss at 12 months. So remote systems work extremely well. They're very attractive to people with severe obesity and medical complications. The subset of DIRECT, which was studied in Newcastle, went through some detailed metabolic tests here. And just very briefly, what that showed was that people with type 2 diabetes have high fat in their liver, in the blue columns, and also high fat in their pancreas. And if they lose weight and go into remission, shown in the greenish columns, their liver fat fell to normal, the pancreatic fat fell to normal. If that's in the blue, they fell to normal. If they did not get into remission, then those falls did not occur. They continued to have high liver fat, high pancreas fat. And if they relapsed back into diabetes, again, the liver fat returned to more or less where it was at the beginning, and the pancreatic fat was unchanged from the beginning. That is kind of very strong evidence now that the ectopic fat in liver, in pancreas, in the heart, and in other organs is damaging organ function and leading to diabetes. Shown here are the images of the pancreas at the top. On the left, at baseline, people with type 2 diabetes using MRI have very ragged, small, sick-looking pancreas. As they lost weight, their pancreas filled out, became more bulky and increased volume, and became indistinguishable from the picture on the right, which is a totally normal, non-diabetic pancreas. The pancreas volume, shown here, increased from about half of normal up to normal. And at the bottom, you can see the insulin secretion was very severely impaired in people with diabetes, about less than half of normal. And that returned over 2 years, already over 2 years, to entirely normal. So the insulin secretion from the pancreas returned to normal in people who achieved remission by weight loss. This is the only treatment that could do that. No medication can do that. We were asked, one of the chats in this meeting has asked, what about people with a lower body mass index? A very small study, which Roy Taylor has also conducted and presented, showed that with a mean BMI of 24.8, people with type 2 diabetes, if they lost weight, 70% were in remission at 12 months, with an average weight loss of only 8%. And again, he showed that in people with BMIs down to 22, if they had type 2 diabetes, the liver and pancreas have high fat level, as shown on MRI, and with remission, they fall to normal. So this just shows that people with the lower BMI, and that's of course much more frequent in Asian people, if they have diabetes, it is because they have too much fat in the liver, too much fat in the pancreas, and they need to lose that fat, which is damaging organ function, even with a lower BMI. Speaking of the South Asian people have a high risk of type 2 diabetes. And we carried out a study, again, a smaller study now. We don't need to do huge studies because the effect size is so enormous from weight loss. This is a study of 25 people, mainly from Pakistani origin, with type 2 diabetes of recent onset, less than 3 years. And what we showed was that with a weight loss, exactly the same weight loss program as in DIRECT, that's the Counterweight Plus program, that we had a remission rate of around about 40% in a randomized controlled trial. And again, their liver fat was high at baseline, fell to normal with their weight loss in achieving remissions. And what we did then was to give the intervention to our control group as well, which is what they wanted, of course. And with a bigger number, we were able to show, again, around 40% remission rate with a weight loss of around about 8%. So this is good news for people with different types of diabetes. And on this slide, I've shown a summary of all the randomized controlled trials. That's DIRECT, the DIET-M1 study, and now the standby study in South Asians, and showing this really quite tight regression line. So the more weight loss people have, the more remissions they're going to get. So the different studies are shown here, including their control groups at the left-hand side. So there is no great mystery about people with slightly different variants of type 2 diabetes. It is important to eliminate those who have pancreatic damage for some other reason, who will not get the remission rate quite at the same rate. As part of the European Association for the Study of Diabetes work in developing guidelines, we did a very detailed systematic review published in Diabetologia last year, which looked at all the published studies which have reported remissions of diabetes with non-surgical approaches. And I've shown here they're colored according to study quality. Again, this is using the AmStar system. So the green means that high quality studies, and there really are only 2 randomized controlled trials here. And those are the ones we mentioned, DIET-M1 and DIRECT, and they're on the left-hand side with an average remission rate of around about 55% against a control group. The other studies, there are 1 or 2 randomized trials, one using a low-fat diet in India, and in the middle here, which is a bit unusual with apparently massive remission rates. It was a very small study, newly diagnosed patients, and mysteriously 100% retention rate at 1 year. I can't say any more about that study. Most of the noise in the media has been about low-carb diets and the theories that people invent to try to explain how they're going to treat diabetes. They're shown here in this pink box. And what that shows is, firstly, there are no randomized controlled trials. And secondly, the remission rates they've achieved are much less than we have achieved with the total diet replacement programs in DIRECT and DIET-M1 and in standby now. So I think if a low-carb diet can achieve weight loss, then they will get remissions. But on average, they're not doing terribly well at the moment. And they certainly don't have any good evidence from randomized trials. Looking more broadly at how we manage our patients, I think it's important to recognize that not everybody does require a formula diet. They're quite expensive. And there are some people who simply don't like them. Now, you could argue that that's an unreasonable approach to a serious treatment for a serious disease. And there is evidence now that type 2 diabetes has impacts on health and life expectancy, very similar to major cancers. And you wouldn't expect people to sort of say, no, I don't like the chemotherapy, I think I won't bother. But people do say that with dietary regimens. But also, there are quite a lot of people who are able to take charge of their diabetes themselves. And if you look in the internet, there are thousands upon thousands of people who are reporting that they have read our results, gone away, followed a weight loss program, and got clear of their diabetes. And Roy Taylor collected up a number following the Newcastle diet. We have produced a slightly tongue-in-cheek diet, which is called No Doubts diet, which is very Scottish, which is able to, if people can adhere to it and lose the weight, then they're going to get them. And anecdotally, of course, many have lost weight and achieved remissions. Also important to recommend that not everybody is going to manage with purely dietary means. Pharmacological treatments are improving for weight management, but important to know that they do not do the job instead of diet. They can only be used as an adjunct. So we still have to have the very best diet, evidence-based diet programs to help people lose weight. And if necessary, to add medication. We're thinking largely of the GLP-1 agonists here. And then we keep bariatric surgery up our sleeve for extreme situations, but we're doing very little bariatric surgery now. This picture just shows the No Doubts diet. There's some bowls of lentil soup for you. Basically, it involves having old-fashioned Scottish porridge, which I love, and lentil soup, which I love, and a piece of fruit with every meal. And then, of course, to move on to weight loss maintenance, we ask people to modify one of those meals in the day, usually the evening meal, but to carry on with porridge and lentil soup as a sort of basic keep your weight down maintenance program. We've designed a very similar program. These are both programs with about 850 calories. With a similar one in Nepal using dal bhat, very traditional foods. And we come back to this time and time again that if we can persuade people to celebrate traditional foods and reject a lot of the modern fast foods and wrapped up, packaged, manufactured foods, that is the best recipe for long-term avoidance of diabetes and perhaps for remission. So here are my summary. Firstly, we should treat weight loss much more seriously. We should do evidence-based approaches and perhaps consider it as important as we do chemotherapy for cancer. We have an optimal diet program now using formula diets and total diet replacement. There are alternatives, but we are now aiming for emissions of 15 kilograms in Europeans, 10 kilograms in Asians in the first instance, and possibly they have to go back and lose more weight as they grow older. There are multiple benefits, which Tony Leeds has pointed out, not just remission of diabetes, and even those who do not achieve remission still have great improvements in their diabetes, reductions in medication, both for diabetes and for blood pressure. But the big focus has to be on long-term weight loss maintenance. And then just finally, we do now have systematic reviews, evidence-based guidelines, which can inform routine practice. And I think things are moving on really quite excitingly. That happy note, I'll say thank you very much and hand back to Dr. Li-Ching Li.
Thank you, Prof. Mike. Very excellent again. I always learn many new things every time you speak. It's interesting. I think Asians may need to lose slightly less weight, maybe, but that's really good. So diabetes remission is possible. We can conquer diabetes. And with that, I would now like to introduce the third speaker, Ms. Louise McCombie. Now, Ms. Louise McCombie is a registered dietitian and a weight management specialist and research associate at the University of Glasgow. Her specialization in weight management covers a span of 22 years, and she's a founding member of Counterweight. Now, you would have heard the word Counterweight used by Prof. Lin, and it's an organization that provides evidence-based weight loss programs. And one of the programs Ms. McCombie developed included the Counterweight Plus, which was used for the direct. And in addition to the direct study, Ms. McCombie was also involved in research around the use of formula-based diets in people with asthma, people of South Asian ethnicity, as an adjunct to medication liraglutide, and finally the use of a novel substrate for weight maintenance. And more recently in March, she was appointed as a Light Health Professional Coordinator for the Healthier Future team in the UK National Health Service, or what they call NHS, Forth Valley. Part of her role in NHS is to implement a healthier future type 2 diabetes prevention, early detection and intervention. And this framework includes the availability of the Counterweight Plus weight management program for remission of type 2 diabetes. Again, Ms. McCombie seems to have a lot of time. She can make use of her time because outside of work, she enjoys gardening, traveling, and I think like fellow dietitians, discovering nice new places to eat. Ms. McCombie, the stage is yours.
Thank you so much for the opportunity to speak at today's really interesting webinar. When I heard that I was being invited to a webinar or a meeting in Malaysia, I was quite excited because I thought, oh, great, some nice national travel. But then I remembered about the joys of technology and webinars, etc. So in my presentation, I'd like to describe how Scotland has taken up a national approach around weight management for the remission of type 2 diabetes. So first of all, I have no competing interests to declare. I think we're all very clear on the impact that studies such as DIRECT has had, not just on clinicians' views around management of type 2 diabetes, but also the public's perception on how type 2 diabetes should be managed. In parallel with the publication of DIRECT, there was activity underway around a national approach in Scotland to health improvement and healthy weight, with remission embedded within the wider Scottish strategy. So there was real direction and leadership on this topic coming from the Scottish Government. Now, first of all, I'd like to discuss 3 key documents that were published shortly after DIRECT was published. So first of all, Scottish Government, A Healthier Future, then drilling down into a little bit more detail around type 2 diabetes, and then finally, standards for adult weight management. So I'd like to go through each of these documents and really discuss the aspects of them that drill down into management and national approach for type 2 diabetes. So first of all, A Healthier Future is really Scotland's diet and healthy weight delivery plan from 2018. So the key vision and approach from this strategic document, you'll see the publication at the bottom of the slide. First of all, children have the best start in life. The food environment supports healthier choices. Leaders across all sectors promote healthier diet and weight, and a target to try and reduce diet and health inequalities. But more importantly, third point here is that the Healthier Future strategic document suggested that people have access to effective weight management services. So this is really a basis, all health boards in Scotland. So within Scotland, we have 15 health board areas, and within each health board, there will be a health improvement board, and they have to come up with health improvement strategic aims every year. So this document is really forms the basis of the strategic approach for Scotland's diet and healthy weight. So it's really contributing to an environment that makes it more conducive to people who are aiming to manage their weight. Again, sticking with the Healthier Future strategy and drilling down into a little bit more detail around the remission of type 2 diabetes. On page 23, we see that of a population of about 5 million people in Scotland, about 1 in 10 are at risk of type 2 diabetes. The authors also recognise, as Tony and Mike have discussed, the clinical implications of type 2 diabetes, such as cardiovascular disease. They also recognise that up until recently, clinicians have been too ready to move to medication rather than going down the route of what we now know is possible to either delay, prevent, or even reverse type 2 diabetes. So a really strong focus on remission of type 2. Again, in parallel with the Healthier Future document, there was a strategic document produced specifically around the management or the early prevention, early detection, and early intervention for type 2 diabetes. Now, some of the aims within this document were that comprehensive provision of weight management services should be made available across all health board areas, and that there should be an increased uptake of these services. Rather ambitiously, I think, the target was that there would be a reduced number of people recorded as overweight and obese. Again, a reduction in complications at diagnosis. So that really relates back to the early detection and the early intervention work. And lastly, and again, I think rather ambitiously, the target for the first 5 years of this work was to reduce the rate of prescribing type 2 diabetes medications. Now, I just want to spend a little bit more time on the actual spend for diabetes medications in Scotland. If you look at this graph, it's a very steep incline. So in 2001, the spend for diabetes medications in Scotland was 24 million. By the year 2020, this had increased to 102 million. And this is something that the Scottish Government were very keen to try and understand more of. And we know, of course, that remission is possible, prevention is possible. So potentially something can be done about this steep increase. So by 2020, £102 million being spent in Scotland per year. I've put in the number for 2021, which potentially suggests a flattening off of the spend. But this is the year ending April 2021. And I think there's definitely an impact of COVID there, which we'll come back to later. Of interest, by 2022, the spend had again increased to a current level of about £109 million per year. So again, looking at a little bit more detail within the framework for prevention and early detection strategic document. Again, this is focusing on the remission programs. Again, they acknowledge that lifestyle-based programs, the mean weight loss is around 3 to 5 kilograms, but remission requires weight loss of a greater magnitude of, as Tony and Mike have touched on, between 10 and 15 kilos. They also recognise within this document the high percentage of men that engaged with the direct remission programme, which again is unusual for weight loss studies, as dietitians in this call will understand. Tends to be very much females attending for weight management, but indirect with a high proportion of males. And moving on to the standards for adult weight management. So as well as these two strategic documents, dietitians working in weight management, along with Scottish Government colleagues, decided to agree on standards for programme delivery across the whole of Scotland. Again, within this document, they recognise the robust evidence for the use of programmes involving total diet replacement. Again, direct was cited with remission rates of up to 46%. And they recommended that programmes should be made available for remission interventions using the agreed criteria from direct. And at that time, the Counterweight Plus programme, which we've mentioned, was recommended for use in NHS Scotland. So moving on to the more kind of national approach. Initially, so it was probably started around 2017, 2018, £42 million was allocated to the framework for type 2 diabetes. So the early detection, early intervention, and remission. But recently we've just heard that this support from the Scottish Government will be continued until 2026-27. The implementation was phased with 3 early adopter sites, and learnings from these early adopter sites was then shared with areas coming on later in the phased implementation. Now, I should say that 42 million does cover both Tier 2 and Tier 3 adult weight management, early detection work, which is pre-diabetes work, and gestational diabetes, as well as the remission work. So the £42 million wasn't purely for remission work. Within the Scottish Government, there are 2 professional leads who are registered dietitians, and they direct the work across the country. There's excellent networking of leads for each of the work streams, so they can communicate on a regular basis to share learnings, to share experiences, and to share new ideas. And also there's a standard database. So data is collected in a standard format, and it's reported back to the Scottish Government, or Public Health Scotland rather, to report to government. So just a very quick reminder, the programme that's been used for remission in NHS Scotland boards is Counterweight Plus, and I think that's been described in detail by both Tony and Mike, so I won't spend too much time going over that. So when it comes to service planning for remission programmes, I think some key considerations are, first of all, we need to engage with key stakeholders. So that's family doctors, practice nurses, diabetologists, pharmacy colleagues, because we're withdrawing medications, and also patient representation is important to get their views. Now, as I'll describe later, the decision was made for the Scottish implementation of remission programmes to have this delivered through dietetic services. So one of the things that was discussed probably quite at length was people at that time were coming to see their dietitian, and it would be best if dietetic colleagues would measure the blood pressures and the blood sugars to avoid patients coming for different, coming to see the dietitian and then having to visit the practice nurse for these measurements. Some dietetic colleagues were uncomfortable with doing these measurements. So anybody in the audience that's considering developing a service such as this, that's a good discussion to have early on and get clarification as to who does what. We need to be clear on who's doing medication reviews. And I don't know what other countries are like, but IT systems within the NHS in the UK are the bane of most people's existence because they tend not to talk to each other. So at this point, all 15 health board areas were probably at the stage of planning or actually underway. So this is around 2019. But I think we'll all remember that something else was coming along in 2019, and that was, of course, COVID-19. So unfortunately, when activity was up and running, there was a redirection of staffing during the immediate pandemic response, which really resulted in a pause in activity when things had just started to progress. However, this did produce an opportunity for innovation. And I think we're all very familiar now with Zoom video conferencing, consultations using Near Me with patients, and really a new way of working. And I think, as Mike touched on, many patients are now starting to prefer this as the route to have their appointments, because it avoids travel, etc. And it did allow managing patients' expectations, because historically people do feel that they should be being seen face to face, but this was an opportunity for a new way of working. So currently, the situation in 2022 across the whole of Scotland, this is a map of all the health board areas. We've got quite a diverse population. Some are very remote and rural, some are urban, quite high levels of social deprivation in some areas. But effectively, Counterweight Plus is now available in all 15 Scottish Health Board areas. 50 registered dietitians are competent in the delivery of Counterweight Plus, and most are band 6 and above. That's in UK terms. The programme is available either by group or one-to-one. The group's currently been delivered in 5 of the Health Board areas. The Scottish Government did make a decision for this work through the NHS that all product would be provided free of charge, and that situation does remain. And lastly, within the standards for adult weight management, it was agreed that psychological services must be made available as part of the weight management, so that people with either disordered eating or eating disorders would have appropriate support and intervention. So the outcomes, again, we can't ignore the fact that COVID-19 did have a significant impact on the activity for this work. So at this point, 300 plus patients have completed Counterweight Plus through this work. And I'm told by the Scottish Government professional advisors that remission rates are tracking well with direct outcomes. However, there's a much larger data collection due in a couple of months, which we anticipate that numbers will have increased significantly. I think general challenges, again, when planning remission programmes, healthcare resources always, shall we say, at a premium. We know that spending now can save later, but trying to persuade funders to do that can be tricky, because there's always competing priorities. Most health services don't have pots of money sitting waiting to be used up. So it may mean making difficult decisions around stopping certain interventions to fund ones that we feel are going to be beneficial. I've mentioned IT systems. Another challenge within the UK at this point, and I don't know if this is global, but staff recruitment is challenging across the NHS. And as Tony has touched on earlier, and Mike also, we continue to acknowledge that weight loss maintenance continues to be a challenge. However, work that we carried out, and it was published in 2018, so this was a service evaluation of an intensive non-surgical weight management programme for severe and complex obesity. Again, it used exactly the same programme, so Counterweight Plus. 288 people were seen in routine NHS settings. Mean weight was 128 and mean BMI was 46. So it wasn't specifically for people with type 2, but there was about a third who had type 2 diabetes. But the next slide just shows that while loss to follow-up at 24 months needs to be acknowledged, those that continued engagement with the intervention showed good levels of weight loss maintenance. So you can see the weight loss at 3 months was about 12.4, 6 months, 15.8, 12 months, 14 kilos, and 24 months, about 13.5 kilos, but with a drop off in attendance. So weight loss maintenance can be achieved, but it's something that we need to probably have more focus. Future recommendations for being suggested from the early implementation sites is a digital tool to scale up delivery. Now, one thing that Professor Leeds touched on is that I think in to add to the Counterweight Plus program, I think sleep support and also stress management should be added into any weight management or any remission program, because they certainly have a big impact on people's ability to maintain weight loss. Scotland is producing an IT solution for data collection, which would hopefully smooth out the challenges that people find. People are asking for more evidence-based programs. We know that TDR works, it's not for everybody. And I think Mike's already touched on the fact that low carbohydrate doesn't have the same evidence, but for people that can adhere to a low carbohydrate diet, there is the possibility that that could be their route to remission of type 2 diabetes. And lastly, again, probably slightly controversial, but because of the staffing issues within NHS, there is a question about commissioning other services to undertake the work. In this publication from the Chief Medical Officer for Scotland, there's quite a nice Counterweight Plus case study, which is maybe worthwhile linking into, so you can hear directly from a patient who's undertaken the programme. And in conclusion, I think Direct has really shifted the focus of management of type 2 diabetes from prevention to treatment, from treatment to prevention. Innovative ways of working are certainly emerging. And we are lucky in Scotland that we've got a very strong infrastructure to support the implementation of remission programmes, and that these remission programmes are standardised across the whole of the country. However, in a final note of caution, we do know that health service resource does remain at a premium. So thank you for your attention, and I look forward to the next presentation.
Thank you, Ms. Louise. It's really heartening looking at the slides that what we see in research is now, it's possible to actually put it into service and on a nationwide scale. Yeah, but of course there's a road ahead, and we have to see and look into sustainability, but really heartening news. Thank you very much.
Thank you.
With that, I would like to introduce our fourth speaker for today, and that's Professor Winichi. Now, Prof Winichi is the Dean of the School of Health Sciences at the International Medical University, Malaysia. She has been in academia for 30 years. Her research is broad and focused on nutritional determinants of bone health in children and adults, vitamin D, and nutrition intervention for obesity, diabetes, and renal. She has been recognized for expertise in evidence-based diet and lifestyle management of chronic diseases, including obesity and diabetes. She was appointed as Fellow of Malaysian Dietitians Association and Nutrition Society of Malaysia. She has also received the Wimpheimer Guggenheim International Lecture Award from the Academy of Nutrition and Dietetics USA, and she has served 3 terms and is currently the President of the Malaysian Dietitians Association, or MDA. Ladies and gentlemen, I bring you Professor Winichi.
Thank you very much, Ching Li, and good afternoon to everyone. First of all, I know that we're kind of running short of time, so I'll do my best. Essentially, what we are going to do now is to share with you the local experience, and this is from the IMU team, on how we've used liquid diet as meal replacements for diabetes patients. These are my disclosures. So in the next, hopefully in the 15 minutes or so, I will cover some evidence for liquid formula diet as meal replacements. We will be discussing a bit on adherence with formula diets, which is also part of if we were thinking of doing for remission. So what can we learn from what we've done with meal replacements? And I have just to think about that if we want to now adapt what we've learned, what our experiences with meal replacement, how do we do it for diabetes remission? So I'd like to just start off to say that the use of liquid formula diets by dietitians so far in Malaysia, I think the dietitians in this currently attending the webinar, we're not, it's not something new. It's already been practiced for a long time. We've used formula diets in the liquid form for very low calorie diets. And this at the moment now is mostly used for pre-bariatric surgery. So dietitians who are working with bariatrics patients, we give LCDs between 600 to 800 calories. and there's some evidence that it does promote some weight loss, reduction in liver volume, and better perioperative outcomes. The other aspects that dietitians are familiar in using formula diets is as a meal replacement. As far as I know, there's no center that's done it for diabetes remission, but certainly when in the last time that MDA did a survey about practices of type 2 diabetes, quite a lot of a majority of dietitians say they've been using formula diets as meal replacement for weight loss and glycemic control. And of course, a large group of the patients that we use formula diets for are the malnourished patients who require nutrition support. So I just thought I should look into what's the difference between total diet replacements and meal replacements. So there may be some confusion amongst us as dietitians. So when we talk, and this I took from the total diet meal replacement European group, which Dr. Leeds is heading this. So total diet replacements is that you're using in the form of VLCDs or LCDs, but these are programs which are based around formula foods. They are nutritionally balanced, but they replace the whole diet, as compared to meal replacement, where we are using it alongside conventional foods as well. So it's part of an energy-restricted diets, is to facilitate weight loss as well. And MRPs also contain, nutritionally balanced nutrients as well. For VLCDs in total diet replacements, it's usually below 800 kilocalories. And the reason is because it will induce a greater weight loss. And with ketosis, that over time reduces the hunger and is very effective for fat burning, as you can see from the direct trial. So what I'm going to share with you is the experiences that we dietitians and researchers in IMU, we've done it for meal replacements. Let me qualify here, we're not doing it for diabetes remission. At the same time, I think dietitians are familiar that for diabetes patients, we do have quite a variety of diabetes-specific formula that we can use for our patients. And these are specially formulated as a meal replacement or to replace an entire meal. And again, the same purpose of reducing calorie intake and promoting weight loss. But diabetes-specific formulas are formulated following the guidelines that's suitable for nutrition recommendation for diabetes patients. They usually contain modified carbohydrates, which lowers the glycemic index of the product and has been shown clinically demonstrated to be efficacious for weight loss, as well as to reduce glycemic variability and overall glycemic control. So just to let everyone know, in the Malaysian clinical practice guidelines now, we've actually put in a statement in the most recent guideline that dietitians should consider using structured lifestyle intervention, and the use of meal replacement have been shown to be effective in lowering A1C, lipid profile, and blood pressure. Similarly, with other guidelines that's related to individualized eating plans or structured meal plans, these are all evidence-based practice at a high level of evidence that they do work for diabetes, weight loss, and lipid and glucose profile improvements. So I'd just like to take us back a little bit. How did we get on board on all of this? So way back in 2013, I think, and I think Dr. Zanaria is here amongst the audience, a group, Professor Mechanic and Dr. Hamdi from the United States was looking at formulating diabetes-specific nutrition algorithm to standardize the practice for nutrition management of diabetes and pre-diabetes care. But they were going around different areas globally to look at something that is more cultural specific that can be done. So with that, a group of Malaysian endocrinologists headed by Dr. Zanaria, family medicine specialists, dietitians, and diabetes educator, we got together and came up with the Malaysian diabetes nutrition algorithm. So essentially, this is not very much different from what we currently have in our clinical practice guideline. It actually recommends a structured lifestyle prescription where we should be looking at low-calorie diets, and also use of diabetes-specific formula as meal replacement. We should also encourage a healthy lifestyle with exercise, and these all should be delivered using behavioral motivation counseling. So a couple of months after that, Dr. Zanaria, myself, Dr. Havinder, we decided to do a sort of a proof of concept that this does work for Malaysian obese type 2 diabetes patients. And we did it in the Seremban Primary Care Clinic together with Dr. Siti Zubaida and other of her doctors. So what did we do? We look at diabetes patients who were overweight, BMI above 23. They were between 30 to 65 years of age, A1C of about 7 to 11%. They've had their medication optimized, but they were not taking insulin. And we decided to then look at weight and HbA1c as an outcome. So this is roughly the research design that we did. So in total, we had 115 patients was in the intervention group. We also had a control group. There was another 115 patients. And the care algorithm that we used was actually both the groups were given healthy eating guidelines for the intervention group. We were doing the meal replacements for them. Both groups, and then for the usual care group, they were following the Malaysian CPG guidelines of using conventional low-calorie foods. They were given education, they were encouraged to do exercise, and there was also a behavior component that they will self-monitor their food and exercise behaviors. For the intervention group, we split the group into half, and half of them we did counseling just through motivational interviewing, whereas the other half, plus the control group, were getting just the conventional counseling of supporting the patients. This was a 6 months intervention, and we then also did a 6 months follow-up. So I just want to show you this. They were given this sort of structured meal plan. So breakfast was about 300 calories, lunch 450, snacks less than 100 calories, and dinner around 450 calories. So roughly around 1,200 to 1,500 calories. These were actually individualized according to the patient's recommendation, requirement. And we had local foods that was being used. So the control group would follow a diet that is low calorie, that's without using any meal replacements. Whereas for the intervention group, they could have 1 meal replacements or 2 meal replacements, and we recommended they take in breakfast or even for dinner, but majority of them, well, it doesn't matter where they take it, but at least if they have to do 1 meal replacement or 2, preferably for breakfast and then lunch or dinner. So they were given meal plans such as this using local foods, and it was also culturally appropriate. So as I said, it's individualized, but they are between 1,200 to 1,500 calories. And we were following the CPG guidelines of 45 to 55% carbohydrates, 25 to 30% fat, and 15 to 20% protein. So the results that we got was actually quite, we were quite surprised with the results, because we saw that with the structured lifestyle and with the meal replacement, while the usual care group dropped some amount of their weight, but slight improvement in A1C, but the counseling, the group that was given the meal replacement had a remarkable weight loss. In fact, both groups had 8 times better weight loss and also better improvement in A1C. And if we use motivational counseling, you can see here that their results was very good, and their weight dropped by 6% and A1C dropped by 1%. So this population was actually around 7 years diabetes. They were about 55 years old. Majority of them had BMIs around 30, 28 to 30 BMI, but they would be, of course, this was not a remission trial, so they were still taking their oral diabetic agents. Most of them at that time, this was almost 10 years ago, they had metformin and sulfonylureas, but they were not on any insulin, but they continued taking their antihypertensive and lipid-lowering medication. So then after the follow-up of 6 months, and just like any other weight loss, and it's what Louise said, maintenance is difficult. There was a slight, it's like they started to increase their weight and their A1C. However, we were quite surprised to see that for those who received motivational interviewing, the results were quite good. They were still significantly lower than baseline, than the usual care group in terms of their weight change, as well as their absolute A1C change. Now, what was interesting here, that if you look at proportion of patients who achieve A1C less than 6.5% after 6 months of intervention, quite a large proportion, a third of them, especially those with motivational interviewing counseling, actually achieved that 6.5%. And in terms of medication, they decreased their medication significantly from taking 2 medication down to only 1. So this actually made the patients were very appreciative of this intervention. We saw significant drops in waist circumference, body fat, systolic blood pressure, as well as other components such as body fat and waist circumference. So recently, Dr. Harvinder then went on to look into the quality of the diet and also the glycemic index and glycemic load of these patients' diet. And we saw significantly that 70% of those patients who received the meal replacement actually also ate a lower glycemic index and glycemic load meal. So you can see here significant drops in terms of GI and GL. But the good point is that even with the meal replacement, their diet quality actually was similar with those that were using conventional foods. Now, what's important also that we learned from this intervention was the monitoring and the evaluation. So the individuals on meal replacement needs to be followed up quite frequently. So we were doing 2 weekly follow-ups in the initial first few months. And after that, subsequently, there was monthly visits to see the dietitian. So the frequency of contact is very important. And secondly, it's important also for us to then to wean them off to low-calorie diets. And also, but however, if they do gain more weight, the continued use of meal replacement is still necessary. And the other thing was the risk of hypoglycemia. Very few percentage of our patients were having hypoglycemia, but if they did, we asked them to check their blood sugar and also bring the records to the clinic so that the doctors can adjust back their medication. Now, of course, one of the key things as dietitians that we think about is how compliant and what would be the difficulty in our patients undergoing such these meal replacements. So this is work done by Ching Li. She had 42 obese patients with type 2 diabetes. We divided them into 3 groups, randomized them into 3 groups. One had 1 meal replacement, another group had 2 meal replacements, and the third group had only conventional low-calorie foods. And we asked them what were the barriers and perceived challenges with their diet. And the results here showed, interestingly, that as long as you're on a diet, every one of them report that there are challenges with, dietary challenges adhering to the diet across all the groups. But we can see here that those who had 2 meal replacement reported higher challenge than those on conventional diet or with 1 meal replacement. In fact, 1 meal replacement was a lot acceptable, even compared to conventional diet. So what are the key challenges? The key challenges that we saw here with 2 meal replacements was actually increased feelings of dietary deprivation. But the benefit that they reported was that they don't actually have to think about food planning. And as you know, if you've been in Malaysia, our food is fantastic. The cuisine in Malaysia is so varied, it's tasty. So it's difficult actually sometimes, and the food environment sometimes doesn't support healthy eating all the time. So taking the meal replacement actually made it easy for them. They don't have to think too much about what they want to eat. And quite surprisingly, those who were on meal replacement said they had less perception of not having adequate social support. So if they were taking 1 meal replacement, the social support was fine, but of course, those with 2 meal replacements, the dietary deprivation was a lot more. So we also, Ching Li and I did some review of 45 clinical trials previously, and we looked at what was the success factors when you're giving liquid diets such as these. Well, it was very clear to us that, and I think this is also reiterated by Professor Mike Lin and Luis, that contact with healthcare providers is very important. For some of these studies, it was weekly contacts, so frequent contacts is needed, and then tapering off as the patients become more acceptable and as they are able to have better self-efficacy. It was important to give structured education and counseling sessions, and it's very important for us to give the structured diet plan, the exercise plan. The psychological motivation was very important, and the close monitoring and self-monitoring of the patients was also very important. So in TDNA, this was what we did. The patients were doing self-monitoring, weekly weight and food records. Menu plans was given, cooking instructions, recipes were given. They learned to also look at nutrition labeling, reading. Strategies to overcome hunger, especially in the initial phase of going on a meal replacement diet, it's important. So things like green tea, chewing gum, mints, low-calorie snacks, or something, but we were not doing total diet replacement, we were doing meal replacements. So all of these strategies was actually very useful for the patients. The other major issue was boredom. So we did provide 14 days meal plans. We gave recipes for preparing the MRPs. They could do milkshakes, they could do smoothies, they could flavor it with coffee. So as long as it's within the calorie recommendations of the meals. If anyone had slow weight loss or gain, we actually pushed them to encourage them to do 2 meal replacements so that they can meet their weight loss goal. And over time, they managed to do that. Physical activity was also important. Behavioral counseling strategies, as we showed you, motivational interviewing was very useful, and we had better results when we were using motivational interviewing for these patients. We published this data by Havinder, showing that when we measure the eating self-efficacy, those who had motivational interviewing had much better improvements in terms of their eating self-efficacy. So it is possible to actually do it. Negative emotions, food availability, social pressures, physical discomfort, positive activities, all of these scores actually improve over time. And I forgot to mention that all in our study, the adherence rate to taking the meal replacement was very high at 96%. So I do believe that it is true that even for remission, adherence rate is actually very good. So if we were to adapt this to diabetes remission, I suppose that is possible. We know that at the VLCD phase, selecting the right formula would be important, dietitians. So in Malaysia, we have to take a look at what are the available formula diets that we can use for VLCDs. Is it necessary to use VLCD alone? We can use also low-calorie diets formulas. Food options, I think, would be important. So local menu plans that can fit into the less than 800 calorie prescription. And of course, behavioral counseling and social support is very important. During the food reintroduction phase, I guess for looking at what diabetes remission did, we have to start introducing one to do low calorie, low fat, and low GI balanced meals. It is possible. We've shown it with the TDNA when we looked into the GI and GL of the diet. With the right food choices, we can actually achieve this. I guess the most important is the maintenance phase. So we saw from the TDNA that majority of them actually went back up to the baseline weight, but still those that were motivated were able to cap below the baseline. So they still have to eat low-calorie diets, healthy eating, a high physical activity. In fact, we found that the group that actually did well after 12 months was those who did significantly higher physical activity, more minutes per week as compared to the other groups that didn't do so well. Eating out is major in Malaysia, so eating out food choices is very important for maintenance. And I think they do need to go back to, a rescue package kind of thing where they have to go back to either a meal replacement or perhaps intermittent fasting. And we need to really tailor this to what is acceptable for the patient to ensure that they don't gain back the weight they would have lost. And finally, we are very fortunate that in Malaysia, there's plenty of companies now that provide digital health support. So, and they have dietitians behind these technologies that's able to chat with the patients and keep the patient motivated as they go along their weight maintenance phase, ensuring that they don't regain those weight and they can remain in diabetes remission longer. But again, we probably need to do a trial to show that this works for Malaysian, and it is very important because we know the rate of diabetes is increasing, and we need to do something to ensure that the slowdown of this happens. So with that, my conclusion would be, I hope I'm able to share with you the structured nutrition intervention using formula diets is possible amongst Malaysian. It actually simplifies the decision-making process. It makes the dietary changes easier to follow. It is effective for weight and metabolic control, but it's very important here. The behavioral strategies and motivation is important. And I suppose it could be adapted for total diet replacement for diabetes remission. I think it can. With that, I'd like to acknowledge all the people who support us along this journey of our team, that we're keen to continue our work in diabetes intervention, as well as hopefully someday we'll do something along remission. Dr. Zanaria, thank you for your support support, Dr. Ctnh, all our patients who believed in us and, followed our plans, and now they're much happier because their diabetes is better controlled, and also to the industry who have sponsored our studies. With that, thank you very much for your attention.
Thank you, Prof Winnie. Let me get my video started. Yeah, thank you, Prof Winnie. So it looks like the use of meal replacements is not strange to the Malaysian context, right? We just now need to see how we can translate that to conquer diabetes, put it into remission. Right, now we have 20, I think that's about 16 minutes left, and I'm going to now open the floor to panel discussion. So what will happen in this panel discussion is we will try and answer some of the key areas of the questions that our attendees have posted. As you can see, very specific questions have already been answered by speakers. You can check the answer that the speaker has for your question in the Q&A box. At least that's what it looks like from my perspective. But I think looking through the questions, they are mainly practice-based questions. So it looks like Malaysians or our attendees today want to do this already. So we'll just start off maybe perhaps with just discussing a little bit about the patient. Is there a good patient fit for this? What sort of patients would this sort of program work best for? Long-standing diabetes, early diagnoses. There was one question that Ms. Louise wanted to answer. Can mothers who are, have just given birth and breastfeeding, can they put themselves into diabetes remission? More men or more women? What's your take on this?
It's a comment more about the new mums. We have clinics for people with gestational diabetes, and the plan within the NHS is that they have an HbA1c done 3 months after baby has arrived. And what we find is that the mums are tending not to come back for that HbA1c, and we're trying to come up with strategies to try and improve that. But I think the general feeling is that the mums with gestational diabetes in particular are just so pleased that baby's okay. So I think engagement post birth of a child for weight loss and diabetes remission, I think it's challenging. The person that's asked the question, if you want to email me separately, and we can certainly look at a bit more detail from the work that's going on in Scotland, because it's a big area of interest.
If you like, I could just give a general comment on top of that helpful suggestion there. As a more general comment, who do we choose to put through this program? Firstly, we published a paper last year led by George Tom, which was looking to see whether we could identify patient characteristics which would tell us who would do really well with this program and who perhaps we shouldn't try it with. And using the direct database, it was clear that really the intervention is so effective that there was no patient group who did not benefit. There was nobody for whom this was a bad idea. There were some who did marginally better than others. So you could say that, interestingly, the older patients and the men did slightly better, but it was very slightly, and it isn't a reason to say that you would restrict it to older people or to men. And of course, younger people have far greater health risks from their diabetes than older people. Under the age of 40, the years of life lost with type 2 diabetes is 15 years. So people who are young, developing type 2 diabetes, are in a terrible state. They are facing an outlook worse than major cancers unless they can get themselves into remission. So probably I would recommend that we should focus first on the younger patients, recognizing that they find it more difficult. And Louise has pointed out some of the difficulties here, that the patients are distracted, they have other things on their minds. Younger people have children, families, and their long-term health somehow gets forgotten. But if we start to ask their children what they would quite like parents to be still there when they're growing up. And we really should be doing more to keep people in program and to focus on the long-term benefits. So I would focus on younger people. The duration of diabetes is important, and we've already had questions about that. Beyond 10 years of diabetes, we know it's much less likely that people will achieve a remission. And that is because two reasons. One, they're tending to get older, obviously, and that with age, there is a greater tendency to put fat into ectopic sites. So probably they would have to lose more weight. And indeed, the people with shorter duration of diabetes who get a remission with, let's say, 10 or 15 kilograms weight loss, as they grow older, most of them are still overweight, and they would probably have to lose more weight. And that's, it is more difficult. And we know already, and from every study ever published, that maintaining weight loss in a world which is trying to give you more food, is very, very difficult. So, we don't have all the answers for this. We're getting better at it. But I would certainly recommend that we focus on relatively recently diagnosed patients, because you will see the results in terms of remission more obviously up to 10 years. But I've had patients with diabetes now 20, 25 years who can get a remission of their diabetes with substantial weight loss. And we're talking very substantial weight loss then. So it's not impossible. And we should not be negative in telling people they won't achieve it. We can actually encourage them. If they don't get remission, they will still get benefits in many other ways from substantial weight loss. I hope that's helpful.
Prof Leeds, you have something to say? Yes.
One of the practical issues that we've all discussed among ourselves is the question of the fact that not all individuals do engage with the program on the first try, and that perhaps we should set a 2, 3, or 4 week target for weight loss, and those who don't achieve that should perhaps stop and then come back to it again 6 months or a year later, because it's absolutely clear from ordinary clinical practice that for some individuals it is not necessarily the right time, perhaps for reasons of stresses and strains and family issues, and that they need to come back to it later. And secondly, there's the issue is they fail the first time. As with smoking cessation, we shouldn't give up on them, that we should try again and again and again. That should really become, Mike, do you think that's right or not?
Yes, of course. Again, within the DIRECT database, early weight loss was a very good predictor of success at 12 months and years. But even the people who didn't do well at 1 month or 2 months, even those people still picked it up later, by staying in program. Now, that was a special group, of course. These are people who have volunteered to do a research trial, and they're going to do better than the average. So I think it's quite clear that if you ask people, are you willing to do this? Are you prepared to do this and try and get rid of your diabetes? There are some who simply, it's not the right time. You're absolutely right about that. Louise may want to say more about that from a practical perspective. Giving them a taster, one of the things which we've adopted, and in fact is now routine with counterweight class, is that we ask people to try the formula diet for a few days before committing, before saying, right, I'll buy into this and I'll pay for it. And that allows them to see, how difficult is this going to be? And in most cases, they don't find it difficult at all. And appetite is, oddly, is not greatly, a problem. So they don't become driven by hunger. The biggest problem is people who've got other things going on, whose lives are complicated. And in the long term, going on to a formula diet becomes boring. So which is why stopping at 12 weeks is probably a good idea, even if they're still substantially overweight or still obese.
I think if just to share for the Malaysian patients who join our study, Prof Lin, most of them were motivated by the fact that they don't want to get onto insulin. So that was one of the key reasons that they joined the study, because they don't want to have insulin. But you're absolutely right. Yeah, that's right.
I would agree with that. And I think in DIRECT, the key driver for wanting to be involved was not even just insulin, but any kind of medications. People said, I don't want to be on tablets. And to try and avoid starting tablets at this point in my life is a key.
Yeah.
And
we did do a 2 weeks run-in with them to see if what they think about it, and actually it is possible. So after they try it, then they see that it's not that difficult. But of course, with our study, it wasn't a total diet replacement; it was a meal replacement. So it was a little bit easier to do because they were allowed to eat some foods, at least 1 meal a day. They could still eat.
Thank you.
Oh, sorry.
In addition to that, from the practical feedback from patients doing a TDR, appetite's not a problem. Tony and I were discussing this yesterday. I'm not entirely sure why that is the case. I had a nice quote from a patient during a food reintroduction phase, and he said, when you introduce one food, he tends to bring his friends along with him. So bread can't be introduced without butter and cheese. Whereas with the total diet replacement, it's there, and it's easy. But hunger, certainly after 2 to 3 days, just disappeared, and we're not quite sure why. I think, Tony, would you agree?
Yes, I'm going to ask Mike actually. What does he think is the mechanism there? I think I know what it might be, but Mike, what do you think?
I know exactly what Tony's hinting at, and there's this unproven suggestion that ketosis somehow reduces appetite. Now, I personally don't believe that is true, and I think the reason I say that is that the biggest, ultimately, if people are starving, they will die unless they eat. They are profoundly ketotic, and they have huge appetites. So in other settings, where weight loss is not intentional, ketosis is clearly not preventing appetite. It's doing the opposite. It's increasing appetite. So I don't think it's as simple as saying that the ketosis suddenly switches off appetite. On the other hand, it is a very familiar phenomenon that people who are trying to lose weight, who go onto a structured diet program or a formula diet with a very clear set of rules, are able to get into this and adopt this as their normal for a period. So the appetite it isn't a problem. We didn't have patients complaining of big appetite. That's not to say there aren't others out there. And of course, again, attracted people who are prepared to do this, who are highly motivated. In my clinic, I've certainly had patients who have done everything they can to reduce weight using diet programs, and they are bedeviled with high appetite. And I think there is a way in which we can overcome that by psychology. And I would love our psychologists to tell us how we can overcome appetite. I don't think it's as simple as saying it's ketosis, but Tony, you may have other evidence on this one.
Well, the thought, of course, and there's some preliminary work from Melbourne, but it's only very preliminary and needs to be redone. What about suppression of the rise of ghrelin?
Yes, so, we showed effects from ghrelin in direct. And in Melbourne, you're talking of Tony Prieto's work, yeah, which was kind of suggestive. What nobody has ever done is give ketones and show that it reduces appetite. And that's a very difficult study to do because you can't just feed people ketone bodies. They're completely unpalatable, horrible, and it would make them very unhappy. I think it's more psychological than it is physiological, because I think our physiology will ultimately drive us to eat more if we're undernourished.
And Ms. McCombie, you have your hands up. Yep.
Yeah, could I add to that? I think there's also an element of motivation and drive. And with the total diet replacement, people are astounded at their weight loss in the first couple of weeks, and it really makes them feel so much better. And again, I don't know if it's psychological, but the number of people that report increased energy. Yeah. Tony and I spoke about yesterday about the better sleep. But when you attend a weight management clinic, you want to lose weight. A pound a week isn't motivational. Whereas if you come back and you've lost 3 to 4 kilos, you're like, this is working for me. And I think that's where the psychology potentially comes in. So the key drivers, if you've got enough drive, they'll stick with it.
I think Louise is completely right about that. Quality of life with weight loss is not greatly improved. If you lose 5 kilos, that's often very hard work, and you haven't got much to show for it. It takes quite a long time on a conventional diet, and quality of life is not greatly improved. If you go onto a program which is showing obvious weight loss, I think people are fired up by this. And it's not just the weight loss, it's also the level of support, because if you have regular contact with a dietitian, and as I say, this can be done with WhatsApp or Zoom or telephone, and that dietitian is positive and is saying, goodness, you're doing really, really well, keep it up, and we're giving them these little tips at each moment, each visit, and that can be weekly or 2 weekly. It's so much easier using remote methods. That actually fires people up as well. So again, I think we're down to the psychology here.
Prof Leeds, yes.
A separate observation. There's a question there about whether, when using intermittent, either total diet replacement or meal replacements, do you need to use vitamin supplements? The answer, I think, is no, because actually the products themselves provide all that's required, and generally the limited evidence we've got shows that it actually can improve nutritional status. We need more experimental work, of course. So my answer to that question would be no.
Yeah, that's very helpful. Now, we have about a minute left, actually, but I think the two questions, maybe we can just quickly move to that. Is there a way we can initiate discussions with our patients about diabetes remission? Because I think it's something new for patients. They don't expect it. How do we introduce? Because I think how we approach the treatment has a lot to do with how engaged the patient is as well. How do we do this in a way that motivates them? And then I think some of the other questions also pertain to weight maintenance after that, right? So if they were to regain, how much weight do we allow them to regain? How do we keep the weight off? Big questions, I know, to be answered in just a few minutes. Yeah.
Okay, I'll give you a quick answer for that. I think you need to change the sign on your door from diabetes clinic to diabetes remission clinic, and that will set people talking. And you know, we've done this, and perhaps in a slightly jokey way. So if you say to people, we're offering diabetes remission, not more diabetes, that actually changes people's thinking. Weight regain is going to be a massive problem. It is a massive problem. For that, you need cooperation with primary schools, shops, the media. Everybody has to pull together to undo the processes that are driving up our weights and making it so difficult for people to keep their weights down.
I would add to the weight regain and, you know, reassure people that weight regain is probably a normal response to weight loss and almost inevitable, but with the appropriate strategies and support and, you know, why were you motivated to lose weight in the first place? So don't make people feel that they've done something wrong because they've gained weight. Tell them that it's a natural thing, that we're here to help them minimize that. And also early, don't let the weight regain go too far before you intervene. And people will know, people tend to know what's happened. You know, they've had a crisis, something's happened, they've gone off plan, and not to be critical of these situations.
Prof Winnie?
Yeah, no, I just wanted to get insights from Professor Mike Lin and Louis and Dr. Leeds also, that for those who actually didn't sustain their remission, was their disease, you know, less severe, or was there still some benefit?
Oh, yes. So the people who did not get remission, still a lot of them have lower blood glucose, fewer medications, lower blood pressure, fewer medications. And the quality of life issue is difficult because in a study like DIRECT, the aim was very clearly to get remission. Those who failed to get remission did feel a little bit upset, and some of them very upset because they really, really, really wanted it. And I think we have to change some of our terminology and some of the approach to patients to make it clear that not everybody is going to achieve it with 10 or 15 kilograms weight loss. Some have to lose more, and some potentially have other damage to their pancreas. You know, they may have some history of pancreatitis in childhood, which we've come across, or something like this, which makes it less difficult, or even a different type. So, you know, within the big population, there are some with some of the rarer types of monogenetic diabetes, which means that they will not become non-diabetic with weight loss, although they will still get many benefits.
I think as well as people that were kind of disappointed, there were a number of people who didn't get remission, but did report that they were pleased how much better they felt having lost weight. So they felt the additional benefits. I think the other thing that, I don't know if Mike and Tony can answer this, but it used to be that from time of diagnosis to insulin was 10 years. I don't know if that's changed now. And that's, as you said, Winnie, that's one of the biggest things that people want to avoid. You know, I don't want to go into insulin. And if their understanding of the pathway that gets them to insulin and how they can affect that, that's a huge driver as well. So I don't know if that's changed. And, you know, for people that have done the program but didn't get remission, are they delaying that onset and also delaying the onset of the dreadful consequences of the disease?
Yep, you're absolutely right there, Louise. The insulin time is still about 10 years. It changes in different countries. So some countries introduce insulin much earlier. We tend not to, and tend to rely on medication. I would also point out there are some people who are successful in getting a remission and are so sort of carried away with this that they disappear and think, oh, well, we don't need to go to the doctor anymore. And even in DIRECT, we have a few patients who got remission at 1 year and 2 years, and we're still trying to chase them up to find out what happened next because they didn't come back for a further assessment. And it's possible that they were just so excited and they remained in remission. I don't think they all went under buses, but Louise is going to tell us the answers on Monday.
Okay. Prof Tony, yes? Yes.
If I could just add, In the light of that recently presented evidence in sleep in individuals with no specific sleep disorders, I'd be curious to know whether those who feel better but haven't actually got remission, to what extent they're feeling better is actually because their sleep is improved.
Or still asleep.
Well, okay, but so I think sleep could be incorporated into sleep observations in all studies. That's what I think.
I would add sleep for the person and sleep for their partners as well, Tony.
Absolutely,
a
yes.
comment that's made.
That Swedish study, there was some evidence for that as well. Yep.
Okay.
Good.
So the time
Great.
now is 5:05. This has been a very interesting conversation. I would love to go on. I think some of our participants also might like for this to go on. If you do, you can indicate that in your feedback survey. Perhaps we could have diabetes remission part 2 and talk about the actual applying or the practice implications. But thank you very much to all speakers, Professor Anthony Leeds, Professor Michael Lee, Ms. Louise McCombie, Professor Winichi. So we have now reached the end of the webinar. And for our participants, before you leave, do provide your feedback. You can either scan the QR code in front of you, or you can click the link to the survey that's on the chat box. And when you fill in the survey, remember to indicate your name appropriately, because your e-certificate of attendance will be prepared based on the name indicated on the feedback form. Right, so with that, on behalf of the IMU Center for Transformative Nutrition and Health, thank you to everyone for attending today's webinar. So let's not give up and let's conquer diabetes. Okay, bye-bye.
Bye.
Thank you, Ching Lee. Thanks, everybody. Bye-bye.
Bye.